So welcome to the second. You're again all rotating through. This is on the diagnosis and risk stratification of AML. This is a topic, and we thought, I guess you've all gone around the room and introduced yourselves before, so I don't know if we need to do it again. Or...
Well, no, it's a new group.
Okay. Yeah, why don't you introduce yourselves then, yeah. Just who you are, whether you're a pathologist or a hematologist.
My name is Luann Bossins. I'm a nurse practitioner at Hennepin County Medical Center. I work in the cancer center.
My name's Amy. I'm an RN in infusion. I'm Teresa. I'm an RN in the U of M infusion.
I'm Alex Hasserjian. I'm a blood marrow transplant physician at the U of M.
Nelly Bejani, I'm the same adult VMT University of Leeds.
My name's Stacy. I'm a lab. I work in the lab at Hutchinson, and we have a small but very active cancer center, so we work very closely with them.
I'm an RN with Fairview on the oncology unit.
I'm Terry. I'm a very experienced oncology nurse, but not working clinically and working in the industry.
My name is Sue. I'm with Stacy and Hutchinson, medical technologist.
Great, thanks. So we're just going to talk about some issues again, interactive. I know we're going to go over some of it's already been discussed in the tumor board, but just in terms of issues, the diagnosis of AML. And I think you're aware, we talked about ruling out APML, classifying always according to the WHO, and then some challenges in establishing the diagnosis in terms of the morphology. So I guess I'd ask you, have you, in terms of establishing the diagnosis of AML, procuring the samples, have you encountered any issues or particular problems that you want to bring up or questions? Well, not necessarily with the pathologist, with just getting to the diagnosis, whatever it takes.
Who performs the aspirates in your institution?
In our institution, we have nurse practitioners and physician assistants on the floor that are certified to do the procedure, and most of the time they do it. I mean, sometimes fellows help out or if they are interested to do that. We also have availability pathologists who do it, and some of it's a training requirement
for pathologists,
fellows and such, and I mean, they do several.
Okay. So who prepares the smears?
Who prepares the technician comes right there, and she prepares.
Yeah. I mean, I can't overemphasize the importance of having a high quality sample to diagnose AML. You have to get an accurate blast count to make sure you reach the 20%. So having well prepared smears that are well stained, I think make sure all those are very good. And I would say if there are issues, then it's good for people to work together to find out what the problem is. We've had some issues recently with cores that are very small and not so great and hemorrhagic, and we've worked with the hematologists at trying to make them get better cores, find some issues of why they were getting that. So I think it's important to try to get a good sample, because not only for all the ancillary tests, but even just for the morphology, for getting the correct blast count.
I would say with our pathologists work, generally, so they prefer the flow to be obtained first before any other samples can be taken. Do you have any?
Yeah, which specimen should be sent first? I think obviously it's hard to put one before the other. I think it's reasonable for the float to be done first, because you can't really tell if it's hemodilute or not, whereas an aspirate, you're always going to get the spicules and you can crush them and go to the areas near the spicules. The problem with the flow is you can't, just whatever it goes in comes out, and if it's very hemodilute, it's going to artifactually change the blast count, the percentage. So I think that's a reasonable approach. I think in our institution, the morphology is always taken first, the aspirate for morphology, and we accept a little bit of hemodilution in the flow cytometry sample. I think, again, as long as you get good pulls for each sample, I think that's the important thing. The other thing is
moving the needle around also.
To get different areas, right, exactly. And then the other controversy is which should be done first, the aspirate or the biopsy. And that's, again, I don't have a good answer to that. I think as long as you go in a different direction to get the biopsy, it's okay if the aspirate is done beforehand. One thing I will say about the biopsy is make sure a touch imprint is done, particularly if you think the aspirate might be compromised. I think that's really critical. Most of our hematologists will do that, but occasionally there have been situations where we get a core and there's no touch prep performed. And they say, well, it was a dry tap. And I say, well, but you had the core before fixing it. You have to put it, and I think, do you all do that? Get touch preps on all cases, or only if you don't get spicules? Exactly. I think that's very important because you don't always know unless you actually stain it and look at yourself if you've gotten an adequate aspirate. So I think that's a very good sort of insurance policy. And I think fish studies can be done on extra touch preps as well. So if the Cytogenetics fails or if it's a very poor sample.
The other thing you could do with the core is they can be disaggregated. They can be disaggregated for flow. They can be disaggregated for culture as well.
So there's some pitfalls in the diagnosis to keep in mind. It's not always that straightforward. We talked about neoplasms with excess blasts. When you have a blast count that's in MDS and MPN that's approaching 20%, 18% versus 21%, that's always hard to say, and it's quite arbitrary. If it's 21% blasts, I call it AML. If it's 19%, I call it MDS with excess blast 2. It could be within the standard of error. So. Well, that's the thing. And sometimes, as I said in the last group, sometimes I will call the hematologist. I said, do you want it to be AML or do you want it to be MDS? Sometimes it depends on what trial they have open. And I probably shouldn't admit that, but I know, and the hematologist knows that it's really an arbitrary distinction, the decision of whether to give induction for over 20 and not less than 20. And then there's things that can mimic blasts, large cell lymphoma cells, other things. And then again, as we said, always tell your pathologist if growth factor has been given and in clinical history, because that can actually transiently elevate the blast count. So there's just a little sort of question to people. So this is an example of patients that were referred to our hospital for presumed AML. Flow hadn't been done yet for cells circulating in the blood that were called others or even called blasts. And only one of them is actually from an acute leukemia case. Do you want to guess which, or decide which cell you think is the real acute leukemia and which ones are not?
I think the B.
This one here?
No, down.
This one. Okay.
Anybody else have a guess?
This one here, big nucleolus, okay. Well, actually, this is from mantle cell lymphoma case. And mantle cell can look blastoid and can mimic, for all the world, in tissue sections as well, ALL. But fortunately, for all these diagnoses, flow cytometry quickly sorts it out. So this is actually an AML blast. Chromatin's a little bit clumped in areas, but there are areas that are quite fine here compared to here. The chromatin is a little bit sort of spotted and lumpy, a little more than you expect to see in AML, despite the very large nucleolus, which you can get in sometimes mantle cell lymphoma. They all have very high NC ratio. Burkitt lymphoma can mimic sometimes AML. I've also seen AML blasts that can have basophilic cytoplasm and vacuoles, particularly pure erythroid leukemias can look like that and can look like Burkitt lymphoma cells. And then in CLL, that's what we were talking about. If you have suddenly a large accumulation of large nucleated cells in CLL, is it a therapy-related AML arising in a patient with CLL, which is not uncommon if they've had alkylating agent therapy, or is it CLL transforming to prolymphocytic leukemia? So again, flow cytometry will quickly address this, but until you have the flow telling you that these are blasts, don't assume that cells that look like blasts are necessarily blasts, because there can be mimics. And then blast equivalence, we talked a little bit about this before, where monocytes, promonocytes versus monocytes can be problematic, and that's really the line that determines if they're blasts or not. And the challenge can be CMML versus an acute monocytic leukemia. So I don't know if you've had issues about that. We talked last time about a patient with CMML, and then now there's 18%, 20, are they blasts or are they promonocytes, or are they just atypical looking monocytes? And unfortunately, immunostains or flow won't help you, because the flow cytometry of promonocytes can be identical to that of mature monocytes. So it's purely a morphologic distinction. So we talked about immunophenotyping. Now, I've shown an image of a cytochemistry. How many of you perform cytochemistry in your labs? Still cytochemistry versus just do flow cytometry to... Do you all do NSC and MPO stains?
The lab people, what kind of labs?
We are like very basic. We don't have.
You don't do MPO, right?
Out, yeah.
On every new leukemia. Yeah.
Yeah, MPO. I don't know if.
Yeah.
I don't know if we even see that ordered very often.
It's not, it's sort of falling out of favor now because the WHO doesn't actually require the cytochemistry. Again, the FAB was based on staining for NSC and MPO in terms of monocytic versus myeloid leukemias. Now we use flow cytometry, but still the gold standard is technically the cytochemistry, and it can be helpful in some cases. So I think it's good to have available, but it's not absolutely required.
Most of our pathologists use it.
Right, it's I think helpful to do. And this is just the markers that are used. I think most of your flow labs will have this available. And do you do the flow in-house, all of you, or is it sent out usually, the flow cytometry at the University of Minnesota? I'm sure I know you have your own flow lab, so it's done in-house. One thing to keep in mind, this might come up in another session, but when we're moving more towards minimal residual disease assessment by flow cytometry, so it's quite important to have a good detailed flow panel done up front so you can see if there are markers, if you have a tiny population of blasts later, to see if it shares maybe some seen up front. So flow doesn't only establish the diagnosis of AML versus ALL, but also can identify markers that can help you, clues to a minimal or relapsing disease later on. And these are these loopholes where we talked about 20%, but you can, these are the only three situations that you can make a diagnosis of AML with less than 20% blasts, and it's defined by the karyotype or by FISH. So, and these can be done fairly quickly if needed.
Fairly quickly. The inversion 16 can sometimes be difficult for the cytogenetics lab to determine, especially if the material isn't that good. So it's nice to have the FISH backup. The manufacturers are coming up with more rapid hybridization buffers that allow the labs to do these FISH studies in a few hours, so that's also very helpful. Again, if less than 20% of the pathologist's blasts are present, and we have this particular abnormality, they can be pretty sure that that's going to be an acute leukemia.
And the PML, the APL diagnosis can be problematic up front. So do you, in your institutions, do the hematologists make that? If the patient's in the emergency room or it's a weekend or something, do the pathologists opine on that, or do you just use your judgment and give ATRA and wait until?
Depends on the situation. Like if clearly clinically, like the bleeding pattern or like smear, definitely I don't wait until
and then
I get the result, any type of results. So because the risk of getting ATRA is
pretty low, yeah.
Who does your cytogenetics?
So cytogenetics is Michelle Dolan and Daisy Hirsch.
No, Betsy.
And these have typical morphologic features, so often the pathologist will suspect these on the smears before the cytogenetics comes back.
And we can FISH smears. So you just don't have to wait to get an aspirate sample to the lab and to culture. We can FISH the smear or a touch prep.
We talked a little bit about APL, but just be aware that other AMLs can have, of course, DIC, and conversely, APL can present without any overt DIC, but can be precipitated if therapy is given, without ATRA, if cytolytic therapy is given. And there are different ways to confirm it. In our lab, for example, I think we're an outlier, but our cytogeneticist, Paula Delchin, prefers to do a rapid karyotype in 24 hours, so we don't FISH up front unless the karyotype fails, or if it's unexpectedly negative, then we'll resort to that. And her rationale is that, well, if it's negative for FISH, we have to do the karyotype anyway, so we'd rather just get it over with and do the karyotype, especially if it's likely to be positive, and then they're finished with it.
Our clinicians would like us to do both, the rapid karyotype as well as the rapid FISH.
Yeah. We often ask our lab, often they will do both simultaneously, but usually the karyotype they can do, and that's the thing, karyotype can be done in 24 hours, but it takes about 2 weeks to get the result. Is that just because of backlog? Or?
It could be because of backlog, but we can do a prelim within 24 to 48 hours, so at least we can let the clinician know what the level of complexity is, and then we can sort it out. And I have to say, we have automated karyotyping systems now that allow us to do the imaging much faster. It's no longer photography and cutting chromosomes out. So the record keeping on that is a lot easier as well. This is an example of a FISH, a single fusion result for a PML rara. So the PML is in red and the rara is in green. So a normal cell would have 2 red and 2 green signals because we have 2 copies of 15 and 2 copies of 17. If a rearrangement took place, the way this probe is configured, you would see a single fusion. So you see it looks yellow And that's the red and the green signals overlapping. And what's our next one?
Yeah. So I think we've talked a little bit about what's needed. Clinical history, we'll talk a little more detail in a couple minutes. The morphology, flow cytometry, the cytogenetics and FISH is needed. And then there's mutational testing. We'll talk about that a little bit later in terms of how this is just sort of a summary. And that's used, of course, to classify AML. And the WHO sort of includes the de novo, more favorable karyotype AMLs, as well as the sort of used in a basket term secondary, which we pathologists don't really like because it includes a number of different things, but I think hematologists like to use it to lump together the poor prognosis ones that occur on sort of, I call it AML with baggage, AML that has some sort of background problem, either therapy related or history of MDS. So the clinical history in AML, one thing that's coming up is this genetic predisposition AMLs that are becoming increasingly recognized in MDS. So do your AML patients see genetic counselors, or or younger patients see genetic counselors at all, or is that?
No, not necessarily. I mean, if we do have like suspicion, probably like Roswell, or now BRCA2.
Right. And then the DDX41.
In those situations, we will make a referral. And generally, like when they are in-house, receiving induction chemotherapy, some of them, insurance, I guess, reimbursement to co-consult that is not required, and not all genetic testing is actually, or the consults can be reimbursed.
Oh, that's interesting. So I didn't think of that.
So
Wow.
it needs to be actually consent for, because they can get you.
That's good to know, because I think there's moving now more towards, maybe realizing these are under-recognized, and of course it could have implications for bone marrow transplant if the patient gets bone marrow from their sibling who has the same genetic abnormality. And then also knowing if there's a history of MDS, MPN, or an overlap, which establishes AML with myelodysplasia-related changes. That has to be an established diagnosis according to the WHO. The patient may have had a history of cytopenias. Maybe you wonder if there's a prior MDS, but technically that doesn't qualify. And this shows why this category of AML MRC is an aggressive disease, because it tends to be a mutational progression from a prior antecedent disorder, and the tumors become more sort of selected for a more particularly aggressive clone. And there are 3 ways this is done. I think the MDS-associated genetics, which we'll talk about in a couple minutes, cytogenetics, I think that definitely has a poor prognosis. I think it's known that AMLs arising for MDS or MDS-MPN are poor, but the most controversial one is if you just see background dysplasia, 2 lineages with more than 50% cells. That requires having obviously good morphology, having sufficient cells to count. I have to say it's controversial. There's some publications that suggest this may not be independently prognostic. So, yeah. It seems like it might not be, although it technically still qualifies. I just want to say, I was talking to someone earlier, I think at the break, that I've seen severe dysplasia in NPM1 mutated AML. So that doesn't, you have to be a little careful. In fact, once I think I called it AML, I said this has to be AML MRC, and then it came back with an NPM1 mutation, so I had to revise the report. So I think again, this is getting superseded more and more by cytogenetics and molecular findings. And if you want to talk.
So how many of you actually see a cytogenetic report as part of your record keeping, or obviously you as clinicians see the reports on a regular basis? Okay. The cytogenetic report has several components to it. There is a nomenclature component that we follow, and then an interpretation that anybody should be able to read. We as cytogeneticists will write it in such language that you can understand what's going on, because it's difficult. So we might use terms like complex karyotype. That would be 3 or more abnormalities that we see. We will also use the terms something like clonal. If we see the same set of abnormalities or a particular structural or numerical gain, that's considered a clone, and if we see it as 2 as few cells, it's considered a clone. If we see the loss of a chromosome, and then that's the only abnormality we see, you have to see it in 3 or more cells. But that can also be FISH confirmed as well, so we can fine-tune that. Did you have a question?
Yeah, we could repeat the last part of when you FP3 in which one you call it for?
If you have the loss
Losses
of
or
a
gain.
chromosome, let's say the loss of a chromosome 7, if we only see it in 2 cells, by definition, it's not a clone. You would have to see it in 3 by convention. But that can be modified a bit if you don't have a good dividing cell population. You can fish to see if that really is clonal or not. All right, so you're only as good as the material that is presented to you. The material sent rapidly to the laboratory. We use a transport medium that contains our tissue culture medium along with some heparin, and it's got a fair amount of serum in it to keep the cells happy, because these cells are growing unstimulated. So it's whatever the innate ability of those cells to divide is. So that's why your labs are always asking you for the sample quickly. Don't refrigerate it. You don't want to slow it down in any way. And they're popped into culture for either 24 or 48 hours. And we can do some things to introduce some synchronization to try to get some better looking chromosomes as well. So your cytogeneticist might use a phrase like, it's unbalanced. Unbalanced means if you look across all the chromosomes, you have a relative gain or loss of genetic material. So the classic examples that you might see in MDS or AML might be the loss of the whole chromosome, 5 or 7, or the loss of the long arm of those chromosomes. If you see P, that's the short arm of the chromosome. Q is the long arm of the chromosome. I've provided you a little bit of a primer that you can take home. That's kind of Cytogenetics 101. That's part of your packet. So hopefully that'll help you out. It's got some good references. And we know there are particular genes that are deleted in some of these scenarios. The isochromosome for the long arm of chromosome 17 or the deletion of the short arm of chromosome 17 result in the loss of P53 that sits on the short arm of chromosome 17. 12P, the ETV6 gene, sits near the top of chromosome 12. You have balanced abnormalities. So you haven't, in a sense, lost any genomic material, you've just rearranged it. And there are specific genes that are involved in many of these rearrangements. If you look at the top example, the 1116, 11q23.3 is a location of MLL. It has a new name, KTM2A, but we'll call it MLL because it's easier to say. So you can see there's the 211 rearrangement. Chromosome 5 abnormalities are consistent through there. So those are other abnormalities that you might see in addition to what we just talked about that have the good prognostic significance, the inversion 16, the 15, 17, and the A21. Can you go to the next slide? Okay. So what does this all mean to the patient? If you're going to look at survival, you can use cytogenetics not only for diagnosis, you can use it prognostically. So your quote-unquote good risk cytogenetics leads to survival of greater than 50%.
Yeah,
I can do that. These guys right here. A normal karyotype drops you down because there are some molecular events that we're going to talk about in a second that are going to modify this. And then you really do drop down in terms of survival. The inversion 3, the inversion translocation 3 is also accompanied in many cases by the loss of chromosome 7. They tend to travel together. And that's a very bad combo. And abnormalities involving chromosome 5 and as well are not very good. So if we go to the next slide, this is a typical karyotype that your cytogenetics lab is going to be dealing with. Now this is one cell. A conventional chromosome analysis will be 20 cells. In many cases, all 20 could look exactly like this. So the cytogenetic nomenclature that runs along the bottom is prescribed, and it describes what's going on. There are 43 chromosomes, so that is a hypodiploid karyotype, less than 46 chromosomes. If we had 48, 49 chromosomes, it would be hyperdiploid. Do you know the sex of this particular individual? What's the sex? Female. There are 2 X chromosomes. That's written next. Commas are usually going to define all these different abnormalities. So every time you see something like DIR stands for derivative, think unbalanced. And what actually happened in this particular patient is you've created a chromosome where the top of the chromosome is the short arm of chromosome 5, and the bottom of the chromosome is the long arm of chromosome 2. So what ended up happening in this particular patient is you've deleted 5q. So if you see something like this and you're not exactly sure how to interpret this, you know, did this patient have a chromosome 5 and 7 abnormality? You call your cytogenetics lab and ask them to describe it to you. And in many cases, if you read their interpretation, they will note that rearrangement deleted 5q. So that, you know, in your mind, you've put that patient in a particular classifier. There's additional material on the top of chromosome 6 that can't be identified. So if they can identify the rest of the chromosome, they'll put it where they think it should go. Otherwise, it would be listed at the end as a marker, an unknown chromosome. So this is described as ADV, additional material, additio in Latin. You've got the loss of 7, the loss of chromosome 13. So this is a complex karyotype because you have more than 3 abnormalities present. It's also a subclassification of that complex karyotype called a monosomal karyotype. And we've written the definition of the monosomal karyotype on the left.
Stop.
We have
I think we have to move over.
Are we getting our...
I think we're getting it, yeah.
Okay, so you have a loss of autosomes, 2, plus a structural chromosome abnormality.
As a
Yes.
poor prognosis, yeah.
Poor prognosis. So that even makes it even poorer than within the complex.
I think we now switch to the next.
I think we're...
He told us, I guess, or
I don't know. How are we doing
guess-
time-wise?
Guess, well, she said to stop, so, but I guess we can, if there are any questions about, until they come and get you, I guess we
Yeah.
still can.
What's our next slide after this? Oh, and this is a break-apart probe for MLL. These are genes that have multiple translocation partners, so it would be impractical for the manufacturers to create specific probes. So this helps the laboratory to know whether a rearrangement took place. So they're defined as half a red signal, half a green signal for each probe. And when a rearrangement takes place, the signals will split apart. So I think you can easily see that this would be, I think we lost this. The top on the left, you see what appears to be a yellow signal. That's the normal signal pattern for MLL. And the red and the green signals have split apart. So that would be a positive for a rearrangement involving MLL. We don't know the translocation partner. We'd have to look at the chromosomes to see what the translocation partner would be.
Okay, I guess
And
we switch rooms.
well, one last slide that talks about modifying, yes.
So just the mutations modify the existence. It's a powerful new thing, but still, aside from NPM1 CBK that are established FLT3, I think the additional mutations are still kind of being worked on in terms of how they should color this stratification. Yeah.
And it also is important for testing in terms of patients who have what we would consider good risk cytogenetics, like the inversion 16 and the A21. You want to make sure that KIT
right.
is tested.
Okay, thanks.
If you have any other questions during the time of the program, please come and see us. Thank you.
Please remember to fill out your diagnosis morphology sheet. And if you have not already turned in your treatment decision making,